Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about amblyopia. I am extremely sorry for not posting any videos since last 2 months because of my personal and professional commitments. Amblyopia is very important topic because here identifying the risk factors which cause amblyopia and treating there itself will bring vision to the patient. If neglected beyond certain age, it can't be reversed. So there lies the importance of amblyopia. So before going to amblyopia as such, let's discuss in short about the binocular single vision, how it happens, what are the different stages, and how if the binocular single vision is affected can lead to amblyopia. Okay. So as you all know, we have two eyes. So we have two images which are formed at the level of fovea or the retina, and the images or the impulses are carried through the optic nerve. At the chiasma they decussate, and again that is carried through the optic tract, and finally it is relayed in the occipital cortex. Okay, that is the visual cortex, and then these two images which are formed by two eyes are fused to produce the single image. Okay, so this is in short how the single image is formed by two eyes. And this process of fusion happens in 3 stages. Okay. In the first stage, there is something called as simultaneous perception. In the second stage, there is flat fusion. And in the third stage, we have what is known as stereopsis or the depth perception. So these are the stages of fusion which happens in the early life. For this process of fusion to happen, two important things has to be normal, that is the motor function of the eye as well as the sensory function of the eye. When I say the motor function of the eye, it means the extraocular muscles as well as the nerve supply to the extraocular muscle. So when the nerve supply and the extraocular muscles are good, the both eyes are kept straight, means there is no obvious strabismus seen. In those cases, both the fovea will receive the same image and the fusion happens normally. The sensory component means the vision input which is given to the retina. So there can be two problems in the sensory system. Either there is no stimuli at all, like in case of cataract or in case of complete ptosis or even in case of vitreous hemorrhage, where the stimuli is not reaching the retina only. Then there is no image which is formed at the fovea or the retina, and there is no question of fusion at all. In the second scenario, the image which is projected to the fovea is not clear. Okay, the image is blurred, like in case of your refractive errors, say hypermetropia, astigmatism, and even myopia. The quality of the image which is projected to the fovea is not good. So the brain fails to fuse the image from the subnormal eye and the normal eye. Then the process of what is known as suppression, which will go into what is known as amblyopia is seen. Okay, means the brain will start neglecting the image from the abnormal eye. Then eventually this eye is suppressed and will end up in amblyopia. And all these things will happen in particular age, that is called as the critical period or the sensitive period of development, which is from usually 0 to 8 years. In this also, the initial 0 to 3 years are very crucial for this normal process of fusion to happen. So if there is any affection with a motor function like squint, with a sensory function like the cataract, ptosis, or the vitreous hemorrhage, or the refractive errors, then the quality of image from the abnormal eye is not good. So the brain will fail to fuse these two images and start neglecting completely the eye which is abnormal, leading to the suppression followed by the amblyopia. So with this background, let's discuss the amblyopia under the headings of definition of amblyopia, the various causes for amblyopia, symptoms and signs, as well as the treatment options. So without much delay, let's begin our video on amblyopia. So what is the definition of amblyopia? So amblyopia can be unilateral or bilateral. With the explanation I gave, you think that it can only be unilateral because the other eye can be normal. But still there are few conditions where it can result in bilateral amblyopia also, that I will be explaining. So it can be unilateral or bilateral subnormal vision. Okay, it is not the 6/6 vision. There is some subnormal vision. But if you examine the patient, there is no obvious ophthalmoscopic abnormality seen, and it is reversible if treated at the appropriate time and with the appropriate methods. Okay, so unilateral or bilateral subnormal vision without any local ophthalmoscopic abnormality, which is reversible if treated appropriately at the appropriate time. This word, that is without local ophthalmic abnormality, means I told so many causes, means they are all local ophthalmic abnormalities only. But if you have treated those, like if the patient is having refractive error, you gave the proper correction. If the patient is having cataract, you did the cataract surgery and placed the intraocular lens. The patient had ptosis, you corrected the ptosis. In spite of all this, once the eye becomes normal, even then there is no improvement in the vision. That is the definition of amblyopia. It can also be defined as a developmental defect of the spatial visual processing that occurs in the central visual pathway of the eye. Okay, so I told it is at the level of the visual cortex which is happening, and hence this can also be defined as developmental defect of the spatial visual processing that occurs in the central visual pathway of the eye. So I already told about the sensitive period or the critical period where all these process of fusion will happen, that is from 0 to 8 years. In that, the initial 3 years is very crucial, that is 0 to 3 years, where there has to be proper motor as well as the sensory input from both the eyes to fuse the image and lead to binocular single vision and avoid amblyopia. Okay, so that is by definition how you define it. So what you see when you examine the patient? Obviously, when you examine the patient, the visual acuity is decreased, the ocular media is normal, that means the cornea is clear, lens is clear, there is no vitreous abnormality or even the evident fundal abnormality also, and there is no obvious neurological defect. Okay, so when the patient has decreased vision with all these normal things, it fits into the definition of amblyopia. What is the prevalence rate of this amblyopia? Usually 2 to 3% of general population is suffering from amblyopia. If you take the preschool children, it is 1.3 to 3.5% of the preschool children are suffering from amblyopia. So there is something called as the amblyogenic factors. That is nothing but which I explained, that is the motor component and the sensory component I told. So if there is something problem with the motor component, that is squint, that is called as abnormal binocular interaction, which is one of the risk factor for the amblyopia. In the sensory component I told, if there is light deprivation, like in case of cataract, ptosis or the vitreous hemorrhage, then also there is no image which is formed at fovea, leading to amblyopia. Or if the quality of the vision is poor, in case of visual deprivation, in case of refractive error, then also there is amblyopia. And these factors are called as amblyogenic factors. And this amblyopia can be classified depending upon the various causes, like the stimulus deprivation amblyopia, also called as amblyopia ex anopsia. So there is no stimulus to the retina. So that is in case of cataract, complete ptosis, or even the vitreous hemorrhage. So there is no stimulus which is reaching the retina, leading to amblyopia. In cataract, it can be either unilateral cataract or it can be bilateral cataract. If the cataract is on the single side, it will lead to amblyopia in that eye if it not treated. If the cataract is on both the eyes, then that leads to what is known as bilateral amblyopia, which I was telling in the definition. Okay. And this type of amblyopia, that is stimulus deprivation amblyopia, has the worst prognosis compared to all other types. Strabismic amblyopia, where the cause is squint or the strabismus. So the image which is formed by the squinting eye is not fused with the normal image which is formed by normal eye. Hence the patient may have diplopia or retinal rivalry, which will lead to the amblyopia process. The next is anisometropic amblyopia, means there is something to do with the refractive errors. The refractive error or the refractive status of both the eyes are different. That is, one eye can be completely normal other eye is having refractive error, or the difference between the two eyes with respect to the refractive error is high. That is, one eye is having very mild refractive error, whereas the other eye is having very high refractive error. In those cases, it will lead to anisometropic type of amblyopia. The next is isoametropic. Again, this is one of the causes for your bilateral amblyopia, where both the eyes are suffering from very high refractive error. Say both eyes are having hypermetropia of +6. Then both eyes will receive the defective quality of the vision and end up in bilateral amblyopia. The next is meridional amblyopia, where the patient is suffering from high astigmatism. So patient is having amblyopia in one meridian. Okay. These two, that is organic amblyopia or the nystagmus related amblyopia, though doesn't fit directly into the definition of amblyopia. The organic amblyopia causes we have like where there is deficiency of cone or the malrotation of the cone. Though when you do the ophthalmoscopic examination, you will not be able to appreciate these changes. Hence, it fits into the definition of amblyopia. In case of nystagmus related, where the nystagmus is very mild, means it is not very well appreciated clinically, but the patient will end up in amblyopia. So these are various types of amblyopia depending upon the cause. Stimulus deprivation amblyopia, strabismic, anisometropic, isoametropic, meridional, organic and the nystagmus. And here is the table which shows the degree of hypermetropia, myopia and the astigmatism in one and both the eyes to lead to amblyopia. What are the symptoms of amblyopia? Usually it is not detected or the patient will not present with any decreased vision. It is accidentally detected either when some foreign body falls into the normal eye and patient closes the normal eye and sees that there is no vision in the other eye. Or it is routinely detected in case of school screening programs where both the eyes are checked. Otherwise, patient usually remains asymptomatic. If you come to the signs, the vision is grossly reduced. Okay. And when to call this as amblyopia? This is very important question to be answered. So, if the vision is less than 612 in spite of all the corrections and the treatment given, that is, you have given the maximum correction, in spite of that there is no improvement beyond the 612 vision, then it can be called as amblyopia. Or if there is difference of two lines between two eyes, okay, with the Snellen's chart, then that is also called as amblyopia. Okay, less than 612 vision or difference of two lines between two eyes, that is amblyopia. If you check the contrast, it is reduced. If you check the brightness perception, it is reduced. And coming to the color vision, in mild cases of amblyopia, like the patient is having 612 or the 618 vision, then the color vision not affected. If the patient is having very gross amblyopia, say like counting finger 1 meter or 2 meter, then the patient may suffer from even defective color vision. There are two important things which you must mention when you write the theory exams related to the amblyopia and when you check the patient. That is crowding phenomena as well as the neutral density filter. So what is crowding phenomena? This is, if you ask the patient to read say 618 line of the Snellen's chart, then the patient will not be able to appreciate the letters in that line. Instead, if you project a single letter of the same size to the patient will appreciate. That is called as crowding phenomena because of smudging of the edges of the letters in that particular line. The patient will not be able to recognize the letters if everything is projected together. If a single letter of the same size is projected separately, the patient will appreciate. That is called as crowding phenomena. Next, moving on to neutral density filter test. So this is how the neutral density filters look. So you choose the appropriate neutral density filter. This test is used to diagnose amblyopia and to differentiate strabismic amblyopia from other types of amblyopia. So if you place the neutral density filters in front of the normal eye, there will be constant reduction in the visual acuity depending upon which density filter you have selected. If you place it in front of the strabismic eyes, then there is slight reduction or there can be even improvement in the visual acuity or the visual acuity may remain same. But in case of other types of amblyopia, there is gross reduction in the visual acuity. Now we have diagnosed a case of amblyopia. Now moving on to treatment. The aim of the treatment is first you should project a clear retinal image onto the retina. Then enhance the neural stimulus to the visual cortex. Means whenever there is a cause like refractive error, cataract or the ptosis or whatever, you first treat this cause and then try to produce clear retinal image onto the fovea. Then what you are doing is you are suppressing the normal eye. Okay, suppress the normal eye and stimulate the abnormal eye. Thereby the vision in the abnormal or the amblyopic eye will improve. So in the treatment we have these options: occlusion therapy, penalization, pleoptics, cam stimulators, and the pharmacological treatment includes the levodopa. So what is occlusion therapy? As I told, here we should suppress the normal eye and stimulate the abnormal eye. So to suppress the normal eye, we are occluding that eye. Okay, means we are patching that eye. So how you patch the eye? You can either patch over the spectacles or you can directly patch that eye with the commercially available occluders or the optic fluids. Okay, or even you can use the cloth occlusion, but the best is to use the commercially available occluders which will completely block the vision to the normal eye. So when we use the occlusion therapy, we have few words here like full-time occlusion and the part-time occlusion. Full-time occlusion means in all the waking hours the patient is having the occlusion over the normal eye, whereas part-time is few hours of the waking time the patient is having occlusion therapy. It can be total or the partial depending upon how much of the light is allowed to enter into the eye, or it can be direct and indirect. Direct, it's called as direct when the normal eye is occluded, and it is called as indirect when the amblyopic eye is occluded. Okay, so you may ask why amblyopic eye is occluded. Because of this direct occlusion continuously on the normal eye, this eye can end up in amblyopia. So to prevent that, we will give a holiday to this normal eye and try to occlude the abnormal or the amblyopic eye. So which type of occlusion to choose, that depends upon the density of amblyopia or the severity of amblyopia as well as the age of the patient. The next is what is known as the patching interval, which is shown in the table. Depending upon the age of the patient, the interval is followed. Okay. Next question is when to stop the occlusion treatment. So you started the occlusion therapy and then you will call the patient for follow-up after 1.5 to 2 months and look for, one is the vision, then alignment of the eye. So one thing I forgot to tell, in case of strabismic amblyopia, you should always start the amblyopia treatment first, that is the occlusion therapy first, followed by straightening the eye. Unlike in other causes of amblyopia where you will treat the cause first and then go ahead with the occlusion therapy, in strabismic amblyopia, start the occlusion therapy, try to make the eye straight as much as possible with the occlusion therapy, followed by strabismic surgery. Okay, so whenever the patient is coming for follow-up, you will have to check the vision, and in case the patient is having strabismic amblyopia, look for the alignment of the eye. If there is even few letters of the particular Snellen's line is improved, then you should continue the amblyopia treatment. Okay, till there is no improvement in vision, at least in 2 follow-up period. Even after 2 follow-ups, there is no improvement in the vision, then you can stop the occlusion treatment. So what are the reasons for your failed occlusion therapy? Either most of the time it is because of the poor cooperation from the patient, or the treatment might have started very late, or the patient may be having latent nystagmus, or the patient may be having some other underlying organic causes. Then only the occlusion treatment will fail. If it is followed properly, usually it gives good results. Then in the next type of treatment, that is penalization, we have what is known as pharmacological penalization as well as the optical penalization. Here also we are suppressing the normal eye by using either medications or the glasses. That when we use the glasses and suppress the vision in the normal eye, that is called as optical penalization, where we increase the power of the glass. Means we add plus lenses to the existing glasses and blur the quality of image which is projected to the normal eye, thereby enhancing the vision in the amblyopic eye. In case of pharmacological penalization, we use what is known as atropine eye drops okay, so that the quality of image which is projected to the fovea is poor from the normal eye. This type of treatment is started when the patient is not cooperative with the occlusion therapy. Otherwise, occlusion therapy is gold standard compared to the penalization. And this usually works in case of only mild to moderate type of amblyopia. And even it can be used as a maintenance therapy if the patient has regained good vision following your occlusion therapy. Okay, and this works best for those with hypermetropic, that is anisometropic or isoametropic type of amblyopias. Okay, that is about penalization or the pharmacological and atropine penalization. Then we have what is known as cam stimulators, where there is continuous stimuli which is given to the amblyopic fovea so that it is stimulated to use. Here the 7 minutes of stimulation of the amblyopic eye is done by using slowly rotating high contrast square wave gratings of different spatial frequencies so that the amblyopic eye will improve. Next we have what is known as the pleoptics, was started very early, which was aimed at restoring the vitality of the fovea and the macula, but this didn't work very well in the treatment of amblyopia. Then in the pharmacological treatment we have what is known as L-dopa, that is levodopa, which is given to the patient to increase the neuroplasticity, okay, so that we can buy some more time to treat the amblyopia, as well as directly also it will help in treating the amblyopia patient. That is the treatment options for amblyopia. So hope this video on amblyopia is useful to all of you. If you like my videos, please do subscribe to my channel. Press the bell icon for further notifications. Please do leave your valuable comments. Thank you so much.